Good evening, everyone. Thank you, Dr. Ramaswamy, for the kind introduction. So let me share my screen here. You guys can see the screen?
Yes.
Okay, perfect. Yeah, so good evening, everyone in India. It's morning here in Houston. And I hope everyone is doing well with all the COVID happening in India. I hope you and your family, everyone is doing okay. I'm sure you guys are busy in the hospital with the COVID issues right now. So, next, maybe in the next half an hour, 45 minutes or so, I will go over this slide deck to review how we use BTK inhibitors in the management of CLL. Certainly, the talk is on a perspective from how we manage things in the United States, but I will, obviously in the discussion part, we can discuss how you guys are doing things in India in terms of the management of COVID, in terms of the management of CLL. So these are my financial disclosures. So just at the outset, I think it's important to highlight that the therapy for CLL has changed remarkably. So previously, up until I would say year 2000, before the introduction of rituximab, really therapy was single agent, alkylating agent, purine analogs, then the combination of fludarabine, cyclophosphamide, bendamustine came along, and then these regimens such as FCR and bendamustine rituximab were developed. And they were really quite commonly used. Up until recently, in the last 5-6 years, now we have several BTK inhibitors, at least 2 of them approved for CLL, Ibrutinib and Acalabrutinib, and we'll talk about those. PI3 kinase inhibitors, BCL2 inhibitor, venetoclax, and also obinutuzumab, which is a novel CD20 antibody. And there are other BTK inhibitor, Zanubrutinib is coming along. We'll briefly talk about that as well. And then other PI3 kinase inhibitors, such as umbralisib, is also coming along, should likely be FDA approved this year for CLL. So at least what has happened in the United States is that with all these therapies, we have really moved away from chemotherapy for patients with CLL. I know, in India, I think chemotherapy is still the most commonly used probably regimen just because of the cost and other issues, but at least in the United States, we have moved away. So, and I think what has happened is that we have moved away from chemoimmunotherapy era, where at that time, some years ago, FCR was given for young fit patients, and you would do bendamustine rituximab or chlorambucil as therapy for older adults, to this targeted therapy era, where at least in our center, we are using FCR for really a very selected group of patients, so which are young and fit. So that I would say maybe less than 65 years of age, no major comorbidities, IGVH mutated. So these are the patients who are IGVH mutated, and then do not have any TP53 deletion, TP53 mutation, or deletion 17p. And if you look at it, that group only constitutes around 10% of all patients with CLL who need therapy, because the median age of diagnosis of CLL is like 70, 72 years. And by the time they need treatment, average age is like 74, 75 years. So majority of the patients are not in this group. So for the remaining 90% of the patients, really targeted therapies have become the standard of care for patients with CLL. And I would also say that at our center, we have not really used FCR, I think, for several years now. We have a new regimen we have been exploring in clinical trials called IFCG, but that's the only clinical trial we have right now with chemoimmunotherapy. But practically, I think right now, 95+% of patients at our center for CLL are getting non-chemotherapy approaches. So what is the standard of care right now for frontline therapy for CLL? So if you, first of all, you need to meet the typical IWCLL treatment criteria. You cannot start a patient on day 1 with Rise stage 0 CLL on a BTK inhibitor because you just want to treat it. You have to have the treatment indications. If you have that, then you'll see if the patient has a deletion 17p or p3 mutation. Now, I would say that 17p deletion is frequently checked for patients, at least in the United States, I'm sure in India as well. But TP53 mutation is not commonly tested, also in the United States at majority of the centers. And I believe this is something which we should be doing routinely. Obviously, it's available in most of the next generation sequencing panel, And I think this should be done because you will pick up additional patients who are del17p wild type, or they don't have del17p, but they have a TP53 mutation. So if you have those patients should get ibrutinib or acalabrutinib. Venetoclax plus obinutuzumab for this group of patients has not shown to be beneficial long-term. I will show you some data. If you do not have that, and patients are young and fit, no major comorbidities, IGVH mutated, then you can do potentially FCR as we discussed before, ibrutinib, acalabrutinib G, or venetoclax G. If patient is unmutated, or any older patient, or comorbidities, comorbidities, the 3 frontline targeted therapies, again, ibrutinib, acalabrutinib, and venetoclax G. So this is the standard kind of practice, I would say, outside of a clinical trial setting at our center. So the focus of this talk is a BTK inhibitor. So I'm going to spend the majority of time on BTK inhibitors and then briefly towards the end talk about some venetoclax-based strategy. But so we have at least 3 BTK inhibitors approved. Ibrutinib is approved, acalabrutinib is approved. They're both approved for CLL. Zanubrutinib is also approved, not yet for CLL, but other lymphomas, and hopefully will get approved as well. So what you see here is the kinase profile where ibrutinib hits BTK, but it also hits several other enzymes. Zanubrutinib is slightly more selective, and acalabrutinib appears to be the most selective among the 3 in terms of the kinases is hit. And its relevance is that and we'll talk about this, some of the side effects of ibrutinib may be coming off these off-target effects, which ibrutinib inhibits. But acalabrutinib and zanubrutinib are they don't inhibit those kinases as well. So maybe that's why we are seeing less toxicity with these second-generation drugs. So ibrutinib is the first-generation BTK, acala and zanubrutinib are the second-generation BTK inhibitor, and then there is also a third-generation LOXO305, which is in clinical trials right now. So let's look at the actual clinical data. So very briefly about ibrutinib. So ibrutinib approval in the frontline was because of this trial called RESONATE-2 trial, which was ibrutinib versus chlorambucil. And recently, Jan Berger from our group reported 5-year data where in the frontline setting, if you just give ibrutinib alone without anything, 5-year PFS was 70% compared to chlorambucil, which is obviously much inferior. So this is a number many times patients ask me what to expect in future. So I tell them ballpark, 5-year PFS of 70%, that you'll be doing well on therapy without progression, kind of thing, 5 years down the line. Ibrutinib has also been tested in this large study called Alliance study, because one of the criticism of the RESONATE-2 study was chlorambucil was the backbone, was the control arm. And at least in the United States, chlorambucil is not really used for patients with CLL. So this study was designed where the backbone is bendamustine rituximab, which is, or the control arm, which is a very appropriate comparison because BR is probably the most commonly, up until recently, the most commonly used chemotherapy regimen, more commonly used than FCR for patients with CLL. So this trial randomized patients ibrutinib rituximab versus ibrutinib versus bendamustine rituximab. These are generally older patients with CLL. And 2 points here, both the ibrutinib arms were superior to bendamustine rituximab. So if you want your patient to have a long progression-free survival, certainly ibrutinib is better than BR. And the second point here is that there was no benefit of adding rituximab. Obviously, using rituximab is just like something obvious. We do it for everything, in B-cell lymphoma, CLL. But it appears that in combination with ibrutinib, there is no benefit of adding rituximab. So we don't use rituximab at all, or we don't add rituximab when we are using ibrutinib for our patients. So now let's some time on acalabrutinib. So acalabrutinib, as I mentioned before, is a new BTK inhibitor or a second-generation BTK inhibitor. And the trial which led to the approval of acalabrutinib in CLL is what is called ELEVATE-TN study. So this is a study which was, again, designed for older patients. You can see generally patients upwards of 65 years of age. And they were randomized into 3 different arms: acala G versus Acalabrutinib versus G chlorambucil. So there were 3 different arms in the study. Just to kind of highlight some of the baseline characteristics of these patients, the median age was 70 years. So again, we are treating older patients in the study, which is typically the age of CLL patients, which are seen in the practice. Other characteristics were kind of balanced across the arms. And this was the primary endpoint. So at 2-year mark, both the Acalabrutinib arms were superior to chlorambucil arm. So clearly, Acalabrutinib is the way to go as part of this trial. But intriguingly, there was a 6 percentage point PFS difference in favor of Acala plus obinutuzumab as opposed to Acala alone. So, and this was actually, if you look at the hazard ratio of Acala G versus Acala, it was 0.49, and the hazard ratio was not crossing 1, indicating that this may be a statistically significant difference, but it's only a 6 percentage point PFS difference. Adding obinutuzumab certainly adds to infusion reaction, cost, neutropenia. So I think a longer follow-up of this study, like a subsequent 3 or 4 year follow-up, will be essential to see how these curves play out. And we're hoping to have that result this year. When they look at the kind of different subgroups, high-risk subgroups of patients, the benefit was seen across, and no real surprises here in terms of favorability of Acala G and Acala versus G chlorambucil. And then again, as is true for BTK inhibitors, majority of the responses were partial remissions. And that is true for ibrutinib, this is true for Zanubrutinib. You can get some complete remissions, but practically most of the responses with these drugs will be partial remissions. And again, that's what was seen here, 85% versus 81%. So high rates of overall response rate, again, which is consistent with what you see with BTK inhibitors. As is true with most studies with CLL, there was no OS benefit. It's difficult to show OS benefit in studies with CLL because obviously patients live long-term and you will have to wait a long time to see if there is an OS benefit. Also, as is true with many of these studies, if you fail G chlorambucil, you can cross over to Acalabrutinib, and therefore you kind of nullify the OS benefit, which may have appeared if the patient was not crossed over. The other important thing you want to look at is the safety profile of Acalabrutinib. So this is the kind of toxicity profile of Acalabrutinib, G, Acalabrutinib alone, and G chlorambucil. What you see here, again, as I was mentioning before, if you add obinutuzumab, you add some myelosuppression, grade 3 or 4 neutropenia of 30% as opposed to 10% if you use Acala alone. So certainly, that would be there. But the most important thing you want to look at whenever you're looking at a BTK inhibitor trials are these events of clinical interest. So which is atrial fibrillation first and foremost. So around 3.4% in the Acala G and 3.9% in the Acalabrutinib alone. So I would say 3.5 to 4% of patients will develop atrial fibrillation, or at least in this trial develop atrial fibrillation with the use of Acalabrutinib. Again, hypertension in a small number of patients. Major bleeding was rare, infections were there, but again, these are something which we see in patients with CLL. So overall, this risk of atrial fibrillation appears to be lower than what has been noted with ibrutinib, where upwards of 10 to 15% of patients can get atrial fibrillation when you're using ibrutinib. So this was the trial which led to the approval of Acalabrutinib with and without obinutuzumab in the frontline setting in the United States. Now, recently, some other data has been published with Acalabrutinib as well. So the trial I just showed you, the median follow-up was like 2 years. So, but what is the longer follow-up we know for patients? How do patients do long-term with Acalabrutinib? We have that data with ibrutinib, but now the data is emerging with Acalabrutinib as well. So this is a study, 99 patients, frontline CLL, median age of 64 years, and this follow-up is now 4.5 years or so. So first of all, everyone achieved a remission on the study. This is the waterfall plot for the lymph nodes, and you can see, everyone had a response, lymph node reduction on this study with Acalabrutinib. And this is the 4-year PFS of Acalabrutinib in these patients. So again, this looks actually pretty encouraging. You have a 4-year PFS of 96% for these patients. So this is a frontline patients getting Acalabrutinib single agent at several clinical centers in the United States. 99 patients were enrolled. And you can see a really nice durability, long-term durability of these patients. So again, another thing you want to look at the atrial fibrillation rate. So because atrial fibrillation, the longer you follow a patient, the more likely you may capture more events of atrial fibrillation. So here in this trial, the median follow-up was 4.5 years. And in 4.5 years of follow-up, 5 patients out of 99 patients develop atrial fibrillation. So the rate, again, around 4 to 5%, which again, as I mentioned previously, better than what we have noted with ibrutinib at similar time points of follow-up. So what's happening with Acalabrutinib in terms of another important study is was called the head-to-head study of Acalabrutinib versus ibrutinib. So this is a large study, 533 patients, where patients were randomized in the relapsed refractory setting, Acalabrutinib versus ibrutinib. So this is a head-to-head comparison. There was a press release issued by AstraZeneca a couple of months ago, and hopefully they will present it either at EHA or ASCO, I'm not sure, but hopefully one of those meetings in next month, where the press release stated that the primary endpoint was PFS, non-inferiority of PFS of Acala versus ibrutinib, which was met. So Acala was non-inferior to ibrutinib. And the key secondary endpoint, which is the atrial fibrillation, was statistically less common with Acalabrutinib versus ibrutinib. But that's the only thing we know publicly right now. So I think hopefully once the actual presentation comes out, hopefully next month, we'll know more about the details of what really happened. But that's a head-to-head trial. At least we know it was equally effective with less risk of atrial fibrillation compared to ibrutinib in a head-to-head trial. Now, Acalabrutinib was also looked at in this large pooled analysis reported by Jennifer Brown, where one of the things the investigators wanted to look at the cardiovascular side effects. So what they did was they pooled together 762 patients from different studies where patients have received Acalabrutinib. And these were different studies in CLL, including the Elevate study, which I kind of mentioned to you about. And then they pooled together all these patients who received Acalabrutinib. And again, just to kind of highlight one point here, 4% patients with atrial fibrillation. So again, that number is consistent across different trials, even this large pooled analysis that around 4% of patients can develop atrial fibrillation after Acalabrutinib. And again, this, again, in their summary, what the investigator stated, again, that this 4% rate, which overall appears to be better than what you would have seen with ibrutinib for these patients. But again, I think when the head-to-head data comes out next month, hopefully we'll be able to compare in the same randomized fashion atrial fibrillation rate between Acalabrutinib and ibrutinib, and obviously compare other side effects as well as efficacy between the two BTK inhibitors. To kind of talk about the third BTK inhibitor, which is also very important in the field, is the Zanubrutinib, which is a BTK inhibitor, which is also like Acalabrutinib, another kind of a BTK inhibitor. And I just wanted to show you kind of one trial from this for this compound. This is 109 patients, and all had deletion 17p. So this is actually just a trial for deletion 17p. Zanubrutinib was given twice a day. The median follow-up is short. Again, you want to look at the rate of atrial fibrillation, which were around 3% here in this study. And then you look at the PFS. Again, these are only del17p patients. So as I mentioned previously, del17p patients, in my opinion, should be treated with a BTK inhibitor. So again, this data looks encouraging. I don't think we can say this is any better or worse than what we have seen with ibrutinib or Acalabrutinib. I think so that's consistent that these BTK inhibitors can provide durable remission for patients with del17p or p53 mutation. So I mentioned about a head-to-head trial of Acalabrutinib. There's also a head-to-head trial of Zanubrutinib versus ibrutinib, which is called the Alpine trial, which is also in relapsed CLL. There was a press release again issued by Jain recently, I think a couple of weeks ago, where they also showed that this trial was met its primary endpoint in favor of Zanubrutinib versus Ibrutinib. Again, we don't know all the details yet. Hopefully at EHA or ASCO next month, these will be presented, and then we'll know more about these. So that was kind of a discussion about BTK inhibitors. So we talked about 3 BTK inhibitors: Ibrutinib, Acalabrutinib, and Zanubrutinib. And I think it's suffice to say, based on what we know right now, that the second generation BTK inhibitors appear to be safer than the first generation, which is Ibrutinib. Now, the other important trial, and again, I wanted to kind of give you a complete perspective in the frontline setting, is a time-limited therapy with what is called the venetoclax plus obinutuzumab trial, or the CLL14 study. In this particular study, let's see if there is a Q&A. Okay, in this particular study, patients were randomized. Okay, in this particular study, patients were randomized to receive venetoclax for 1 year plus 6 months of obinutuzumab, or chlorambucil for 1 year plus 6 months of obinutuzumab. And this was recently updated at the ASH meeting now 6 months ago. So these patients, the median PFS at 4-year mark was 74% for ven obinutuzumab. So these are the patients who basically get 1 year of therapy, then you stop their venetoclax, and this remaining part of the curve, the 3-year part, which is shown here, is without therapy. They're just being monitored. And what you see here is that the curve, it has a slope to it. Patients are slowly relapsing. But again, this is a long treatment-free period for majority of these patients. And it's still at 4 year, 74% are progression-free. Now, one thing I mentioned is that for patients with deletion 17p or p53 mutation, this may not be the right strategy. Why that is that there were 25 patients in this study who were deletion 17p or p53, and that's the curve here, this blue line here. And what you see here is that when they stop therapy at 1 year mark, you see kind of these progressions in this step ladder kind of a pattern here. So these patients are progressing after you stop their venetoclax. If they did not have p53 mutation or deletion, then they are doing well. So based on this 25 patient study, or 25 patient cohort, I should say, the argument has been that these patients probably need BTK inhibitor, because I showed you previously the data with Zanubrutinib, and the similar data is available with Ibrutinib and Acalabrutinib, where they can get durable long-term remission with a BTK inhibitor. So at least in the frontline setting in the United States, we now have 3 approaches: Ibrutinib, Acalabrutinib, which again is with and without obinutuzumab, you can use it. And then venetoclax is typically combined with obinutuzumab. There are pros and cons of these approaches, and this is something I discuss with my patients in the clinic. If they're not going on a clinical trial and they want to get a standard therapy, Ibrutinib obviously had the longest track record, but it's an indefinite therapy, low rates of CR, and then atrial fibrillation rates are high. Acalabrutinib has less off-target effects, so it overall is better tolerated than Ibrutinib, less dose reductions, less risk of atrial fibrillation compared to Ibrutinib. And the venetoclax obinutuzumab certainly has an advantage of being time-limited therapy, but then we don't have long-term follow-up of this data. You have to watch for the tumor lysis syndrome. Obinutuzumab is given IV, so you have to get them to the hospital or the clinic to get it. Neutropenia rate is high, so you have to watch for infections, or many times they need growth factors, GCSF support. And then the p53 patients, as I mentioned in the previous slide, do not do well with this therapy. So now looking at some kind of future directions in the last maybe 5-7 minutes is we talked about therapy as BTK monotherapy. We also have these doublets, BCL2, which is venetoclax plus antibody, Acalabrutinib plus obinutuzumab. But we and others have started to look at now doublets of BTK plus BCL2, And also the triplets are coming along where you kind of all three classes of drugs, you mix them together. So let's briefly look at it. So we have been working on this combination of ibrutinib plus venetoclax for patients with CLL. And we reported initially this data in New England Journal a couple of years ago, but this was an update presented at ASH and subsequently, hopefully, will be published soon. In this, we treated 80 patients with ibrutinib plus venetoclax. So there is no antibody here, 2 oral drugs. And what we did was, first 3 months was ibrutinib alone, and then the patients added venetoclax. And then the venetoclax plus ibrutinib combination continued for a total of 2 years. And then we did serial bone marrows on these patients, and these are all intent to treat analysis, 80 patients. So serial bone marrow, so what you can see here is that at 1 year mark, 56% were MRD negative on an intent to treat, 66% at 2 year, and as a best response, 75% of the patients were MRD negative in the bone marrow with these 2 doublet regimens, 2 oral drugs without any need for antibody. So that seems pretty encouraging for patients that you can achieve such a depth of remission in large number of patients with 2 oral drugs. And this has been now confirmed by the large Captivate study, which is kind of a similar trial design, but much larger international study, where again, patients get the same thing, 3 months of ibrutinib, then you do the combination of 1 year, and then they have some randomizations based after that, but let's not go into that right now. But it's suffice to say, when you do this regimen for 1 year, and they treated 164 patients in the series, 75% in the blood and 68% in the bone marrow were MRD negative. So again, this is a large international study, again, confirming very similar data, what we reported from MD Anderson single center study, that you can achieve high rates of remission in a time-limited therapy with the combination of ibrutinib plus venetoclax. Now, very quickly, the other thing which is happening now is this triplets. Again, these are early data. What triplet basically is, you have a BTK inhibitor. So a couple of studies are looking at ibrutinib. There's a study with Acalabrutinib, and there's a study with Zanubrutinib, and you combine them with venetoclax plus obinutuzumab. So that's kind of a triplet studies. Everything has Ven-G in it, and then you choose your BTK inhibitor. Small number of patients. The follow-up also of these studies has been relatively short right now. But overall, I think, again, high rates of MRD remissions we are seeing. Whether these are better than just the doublet of ibrutinib plus venetoclax, that's something we don't know right now. I think we need to get more number of patients treated with these drugs, with these triplets. We need a longer follow-up of these data to see whether you need triplets or you can just do very well with 2 oral drugs, such as ibrutinib plus venetoclax. And some of these data will come to us, hopefully in the next couple of years. What this slide shows is a first-line phase 3 trials currently happening in the CLL field. And many of them are actually have fully accrued. We're just waiting for the results. And then if you look at, they have a control arm. Control arm has been chemotherapy. And then they have a variety of randomized arms. For example, the UK FLAIR study, a very large study, 1,500 patients. Patients are randomized to FCR versus ibrutinib rituximab versus ibrutinib alone versus ven plus ibrutinib. So again, this trial will help us know whether you need this doublet is better than single agent ibrutinib. CLL13 study looking at the chemo versus Ven-G versus Ven-R versus the triplet. And again, this study I'm actually looking forward to because this is probably the only study which is looking at Ven-R as a randomized arm. We always think of G, obinutuzumab, being superior to rituximab based on the CLL11 study where the combination was with chlorambucil. But we haven't really proven that in the context of new drugs, that whether rituximab or obinutuzumab is better than rituximab. But in this study, there's a head-to-head comparison, so we'll know more when this result is out. Similarly, this particular study, chemo versus Acala-Ven, so double 2 oral drugs versus the triplet. So again, we'll see that. And then if you look at the more recent studies, these are studies which are ongoing right now, where actually they have gotten rid of chemotherapy completely, no more chemotherapy. And then patients are being compared to ibrutinib versus other combination strategies. So again, these studies are not, they have not been reported yet. So I think I'm hoping that some of them will be reported in the next 1 to 2 years. And again, some of these comparisons will be very informative to see what is the ideal combination for these patients. So my second to last slide here, just kind of looking at the frontline therapy for CLL, you see that we do already have BTK inhibitor, so like ibrutinib, Acalabrutinib approved, with and without antibody. We have BCL2 inhibitor venetoclax approved with antibody. But these combinations are happening, doublets, 2 oral drugs, or triplets. So we don't know which is the best one. Kind of the time will tell, but hopefully these randomized trials will help clarify. One of the other things when we're talking about target therapy, time-limited target therapies is what is the ideal duration? Should we do treatment for 1 year or 2 years, or should be MRD based? So that's something which is not clear right now. Trials are looking at different duration of strategy. So we'll see how the results pan out. Because one of the things you have to realize is that when we were using FCR, when we're using bendamustine rituximab, it was a time-limited therapy of 6 months. And then you obviously stop the therapy, you see what happens to the patient. If they relapse a few years down the line, you can use the same thing again. But then came the BTK inhibitors, where the goal was, oh, you need to give these therapies for the rest of their life. So now the field is kind of dialing back to say, hey, yes, we need to use the target therapies, but can we cut back? Can we develop a time-limited approach again, as we were doing it in the era of chemotherapy? So in conclusion, hopefully I have kind of showed you data with second-generation BTK inhibitor with Acalabrutinib, which appears to be equally effective, at least based on the randomized study. Again, we don't know all the data, but based on cross-trial comparison, it appears to be equally effective and safer than ibrutinib. And again, as I said, the head-to-head trial data is awaited. And then there are lots of kind of combination strategies happening right now in clinical trials, including many in phase 3 studies, which are still awaited. And I think it will help decide how we manage patients with CLL in the next few years to come. So thank you for your time and attention. This is my email address. If you guys want to reach me out later, please feel free. I'm always happy to answer questions or discuss things with you guys. And we'll open up for, I guess, the next part of the symposium. Thank you.